my goal today is to ask these professionals questions that I'm curious to understand, and questions that we've been hearing from our colleagues, from consultants, and from employers. And so I don't want to put a lot of pressure on you, Carter and Sylvia and Michael, but people want to hear what you have to say. So why don't we start there? And I've got your pictures, your glorious pictures put up here, your profiles, but why don't we just go down, and I'm curious from each of you, Michael, Carter, Sylvia, why you chose to be a provider, and maybe just give a little bit about what you do, what your practice is, if you're a therapist, a physician, and kind of what you do. So Michael, let's start from the top. Welcome.
Yeah, thanks, Nate. So I'm a clinical psychologist, and I'm the mental health program manager for Crossover. So I am responsible for our entire national mental health program. I think getting into the field was really around a strong value around wanting to help others and reduce suffering in the world, and started, as a psychologist, just really focused on individual therapy, and increasingly just wanting to look at systems, because the mental health system is just really broken, and we need to fix it in order to help more people.
Great. Carter.
Thanks. Thank you guys for having me. My name's Carter Carmy. I'm a psychologist. I'm based out of Detroit, Michigan. What really got me into this field was a crazy idea when I was younger about trying to understand the world. When I was young, a book came out called The Bell Curve, and it was talking about the factors that our intelligence was related to our genetics, which seemed like a really myopic way to view the way that we function as humans. And as I got older, I really got focused in trying to understand what are all the other factors that kind of influence them. That's how I got into the field of psychology in undergrad, and had the opportunity to work with some great providers and great researchers early on in my career, and that kind of led me into this field of health psychology, where starting to see how all these different factors, not just our genetics, not just our where we live, but our interactions with the people in our lives, and the factors that influence that really can impact who we are as people and how we move through the world.
Excellent. Thanks, Carter. Sylvia.
Good morning, everyone. Sylvia Chetty here. I am the lead physician at our Crossover Midtown Manhattan clinic, and I'm a family practitioner by trade. How did I become a provider? Essentially, I loved the sciences growing up, and hence that led me to the path of getting into medical school. But really, I think in medical school is when I discovered I'd love to build that relationship with patients and really make an impact. And that's really what led me to primary care. I think it's an awesome field to be in, one of the most rewarding, in that you can really be the driver of people's health and well-being for a long, long time. Excellent.
Love it. Thanks for sharing. All right, I'm going to get rid of those slides and close this out so we can see your faces a little bit better. But why don't we get started? And maybe one of the basic questions that I'm curious to understand is, Michael and Carter, you guys both work in health centers and serve in a mental health therapist capacity. What are the types of issues that you're seeing in these employer-sponsored health centers where you work? What types of things walk through the door and that you're helping to treat?
I think some of that varies a little bit depending on what population we're talking about, but we definitely see a lot of anxiety, a lot of people who in our world struggle with work-life balance and the pressures of being a great employee, being a partner, being a parent, managing all of those things. And that comes in a lot, relationship concerns, depression. I think those are the big ones that walk through the door, but I think Carter, particularly for the population that you work with, might see some different things.
Absolutely. And I think for the population that we had the opportunity to work with our employer based in Michigan, it really ends up becoming really similar to the population of what's going on in the local area. When there's tragedies, things of that nature that occur, say at Oxford or Michigan State, these things really have a big impact on the individuals that we're seeing. So we see a lot of traditional anxiety and depression, but we're also seeing a lot of individuals struggling with some difficulties managing trauma, or also coming out of the COVID pandemic, the isolation that has kind of occurred from their maybe groups that they were typically involved in have been fragmented, or not engaging in the same ways that they had previously. And really trying to manage that to figure out how they want to move forward in their lives.
Great, thanks. One quick housekeeping item is that for those that have joined, the attendees that joined, there's a Q&A button on your screen, and feel free to use that. We'll be monitoring that to capture questions that come in, and we want to make sure that we grab some of your questions and ask our panelists. Sylvia, let me ask you, you're a primary care doctor, right? And so I imagine that people are scheduling, primary care visits with you, annual physicals and such. Are you also identifying mental health issues among your patient panel?
Absolutely, 100%. And in fact, that has grown significantly during the pandemic. So I would probably say, historically, we'd probably see about a third of the population dealing with some mental health issues, or a quarter rather. And I think that's gone up to a third or maybe even beyond. And as Michael and Carter pointed out, not only the bread and butter, anxiety, depression, work-life balance, relationship issues, work stressors, but now, of course, the impact of social isolation, working from home, financial stressors, colleagues being laid off. I also work with patients that are in media, news, and just everything that's going on in the world. So having to really deal with that on top of everything else that we've always seen in primary care. So definitely seeing a lot of mental health struggles.
So Sylvia, from your perspective, help us understand, a patient walks in and, I can imagine that like, hey, I feel achy or I feel sick or something's wrong. How do you begin to understand? I mean, because they're coming to you, they're not coming to mental health. How do you begin to be sensitive to say, hey, there's something going on here that needs some mental health support? And then how do you actually get that? Because I know we work in these integrated health centers where we have primary care and mental health and coaching and physical therapy. How do you then make it comfortable to help transition a person to a Carter or a Michael or one of their peers in your health center?
Great question. Well, I mean, I think, the uniqueness of Crossover is that we're able to spend more time with patients to really establish that trusting relationship with patients. And I think that's so important, because I think when we talk about the outside world, we think about those 15-minute visits and revolving door, and you only have time to really, treat the cold or the acute matter. And really at Crossover, we have more time to spend with patients. And I, as a provider, and I think I can speak for the other primary care providers within Crossover, we like to really get to know our patients and get to the root cause of things. So it's not only addressing their cold or their UTI for the day, it's really seeing, taking that holistic approach to say, well, what else is going on in your life? And let's take a look at these social determinants of health, whether it be through our screeners that we have with patients or just informally, what's been going on. If someone comes to me and says they're having a hard time sleeping, well, what is the struggle? I'm not just going to prescribe a medication for sleep without trying to really get to the root cause. And I think we have great rapport with our patients. We're able to establish that trust and really get to the bottom of things. And many a times we do see that it is a mental health issue that they're dealing with that then needs to be addressed by a mental health provider who's really the professional in that.
And
do you find, real quick, Carter, Sylvia, do you find that it's hard to then hand that person off or introduce them to Carter or to Michael? I mean, are they open to that, or are they reluctant to say, hey, I don't know that I want to meet with a therapist? How do you experience that?
Within our setting, I think many a times they're very open to it, or it may take a little, bit of time, but I think if we have a great relationship with our patients, they are more willing because they're trusting. And not to mention, we're not sending them to some random person in the community. We're sending them to a practitioner that we work with very closely and know. And so definitely that eliminates that barrier. And then not to mention, many a times I'm able to get them scheduled for that appointment at the end of the visit. I have access to the schedules. I know what the providers are able to address and what their niches are, and I'm able to schedule that appointment right away at the end of the visit. So we're not talking about, here's a referral, like we're going to take some time to process this. It's really immediate access to care.
In
Great,
kind of
Carter. Sorry.
Yeah, no worries.
Go ahead.
To piggyback off what Sylvia's saying, I think one of the things that we really got the opportunity to do here at Crossover, at least I know in our market as well, here in the Detroit area, is that we not only do we spend time developing relationships with our members, the individuals that we're treating, but also we develop relationships with our providers. And when we're thinking about how us as people, we do take recommendations, we go, if I'm looking for a haircut, I'm going to go to the person that I like my friend's haircut. I'm like, hey, where'd you get your haircut? Oh, I saw this guy. And he's like, even and similarly, when it comes to like our other aspects of our health, is like, hey, I have a mental health person. This person I really trust. The way they address things is really valuable, and I think they could be helpful for you. And I think by having those personal relationships with us providers, really is a big add. And in those times when people are presenting with primary care, us as mental health providers, we're more than happy to kind of hop into that appointment and take 5-10 minutes, introduce ourselves, kind of hear what's going on, and then but also kind of give an introduction, because sometimes people don't really know what mental health is, and getting that introduction can be really valuable.
Yeah, I mean, I think lowering the barrier to entry probably means a lot. I'm curious, for all three of you, you guys have probably worked in different settings before Crossover. My sense, I don't know them all, but my sense is they weren't collaborative care settings. What do you find different about having all these resources, or about the Crossover model, about all these resources being under one roof versus like how you did it before in your prior practices, wherever it was?
I think understanding health benefits is actually really complicated and hard for a lot of people, and our healthcare system isn't easy to navigate. And so I think it's just so easy for people to get lost in the system. And I think that's one, I think it's so much easier when everybody's in one place, and that certainly makes things easier. But I think one of the struggles I've always had in other settings, and even in systems, I worked in Kaiser, which is a integrated system of a different kind. I could send a message to the primary care doctor who's treating my patient, but I didn't know them, and we never developed a relationship and trust in the same way that I'm able to with the doctors here. And because of that, it just allows for a much better care experience for the people we serve, and a much better professional experience. You don't feel like you're on an island all the time. And I think mental health providers so often have that experience of feeling like, hey, I'm in this on my own. I can't get a hold of anybody who's working with my patient. And it can be demoralizing. And so we don't have that problem here. We have a much better care environment for the providers.
Gotcha. Let me ask, there's some questions coming in from the attendees about just our collaborative care model. And, I'm curious, the way that we practice, I'd love for you guys to kind of talk about that, of how we're working as a integrated team and what it actually means to be collaborative on a patient. If I was just a random professional and I was scrolling through LinkedIn regarding mental health, it would seem to me that a lot of the solutions out there are text-based. It seems very simple, and like, hey, to get mental health therapy, it's I can text a question, text my issue, text this, text that, and it's gonna be resolved. My sense is it's a little bit more complex than that. I don't know. Maybe it's a text-based solution, works really well. Chat GPT is a little scary, so maybe they've harnessed you guys and put you in AI, and now we're becoming obsolete. But I'm really curious, from the contrast between what is really, when people say a collaborative care model, I think people throw that term around loosely, and it can mean a lot of things, to what is happening in the industry with a lot of the run-of-the-mill solutions. So help me understand, what is a collaborative care model? How does it actually function?
And I think the first thing to say, Nate, is there's a kind of an evidence-based approach called collaborative care that comes out of the University of Washington. And I think there's a question in the chat about that. And that is not the model that we're utilizing at Crossover. We have a different approach. I think in ours, we really want, I think the problems are maybe a little bit more complex than that. And collaborative care model out of Washington tends to be very medication focused. And in ours, we really do, we have therapy, what highly flexible therapy right there on site. It sometimes is shorter term, it sometimes is longer term, but it's right there on site. So in that sense, it is collaborative. I think the thing that I would say about what you're referencing with LinkedIn, and everybody's trying to solve for mental health right now, it's really hard. There's provider shortage, it's hard to scale it. And so people are looking for kind of tech shortcuts to do that. Coaches, there are so many different ways that people are trying to solve for this. And I think the thing that I think a lot about is that what we know is helpful in therapy is still the relationship. All the common factors research points to this, that having a close, strong therapeutic alliance with a provider is the biggest driver of change in mental health. And I worry a lot about some of these solutions that are, like self-paced CBT apps, things like that, that's getting lost, and just wonder how effective that is if that relationship is not present.
Yeah, well, I can kind of add on to that is because some of the literature I've looked at revolving some of these text-based AI therapy is that it's effective until the person realizes they're not talking to another person. And that kind of falls off. But to kind of, because as you asked that question, Nate, you asked kind of two questions. You asked about what are the solutions right now, but you also asked what is collaborative care. And I think one of the things that often gets conflated is co-located care and collaborative care. So a lot of places you'll see is like, oh yeah, we have all these things. You'll see this, especially in these large health systems. The one close to me is the Henry Ford system, that they'll say, yeah, we have mental health, we have physical therapy, they all exist. And I've been in those systems before where, yeah, the person may be in the next office next to me, and I don't see them more than twice a year, or much less talk to them. And that's not really the nature of the relationships that we're developing here at Crossover. We're thinking about the way that we've been focusing on the way we're treating our members, not just for mental health concerns, but all of the concerns that they're coming in with, is that how are all of us as a provider team working to care team really working to help an individual get better. And I think that's where we're highlighting the value of these relationships, that are the value of relationships, because what also occurs in this relationship is that we have that flexibility to know what's not working, what is working, and that there may be a need to shift an evidence-based treatment. Maybe an individual is responding well to CBT and then stops, and they need an act-based approach or an EMDR-based approach. But if I'm just on an app, I'll just exit the app if it's no longer giving me what I need, and I'm going to disengage. But by having that relationship, we're able to kind of check in and move and make sure that we're moving care in a way that's necessary and that's needed, adding that medication management piece in.
So let me ask another question, real quick, and then well, Sylvia, go ahead, jump in.
If I may just add to that, I think I'm going to make a very similar point, but it's so important and valuable in that, many a times, again, these systems have that collaborative approach. They have the providers, they're all under the same, roof or name, but they're not talking to one another. I have full access, to, what visits patients had, but, in other care settings, you can't grab that provider in the next room and say, hey, I just saw so-and-so, what is your take on it? Are we aligned in the treatment plan and the patient's goals? And that is what really sets us apart. You don't have that everywhere because, again, to Carter's point, you might see someone 2 times in a year, but not really be able to fully collaborate with them with regards to patient treatment.
I think that let me just, one observation that comes out is like, from my perspective, and we'll talk about this a little bit later in this discussion, is like, I think then when some of these issues are fastballs down the middle, if you could care to characterize one like that, it really goes nonlinear when you're starting to talk about social determinants of health. I mean, those things, I'm just thinking about you, Carter. You were talking the other day about how you spent time on the phone trying to help one of your members navigate the system. And it didn't even, I mean, you were trying to help your member solve something. And I'm like, there is no AI bot for that. But let me ask a question, because we're going to jump to some of those SDOH issues in a second. I like what you guys are saying, but at the end of the day, what matters to me, as I'm a self-funded employer, I'm on our benefits committee, like, how do you know the members are actually getting better? Because really what I care about is, like, if there was a very, non-conventional path to help a member get better, but they were getting better, like, that sounds great to me. I just want to know that my employees and their family members are improving. So, how do you guys know that people are improving?
Crossover, we have a strong measurement-based care approach, and measurement in mental health is always interesting because all of the measures are subjective. It's not taking a blood pressure or something like that. It's based off of self-report, and it's still really valuable. And so we actually measure on a session by session basis how people are doing with their symptoms, how they're doing with their therapeutic alliance. And it's not just beginning, middle, and end of treatment. It's consistently throughout care. And that gives the therapists and our members information about how therapy is progressing, gives them a chance to course correct when things aren't working. When somebody's scores are remaining the same session after session, it's a really important opportunity to review the treatment plan, review what's happening in care, review if it's the right provider. So we're doing that consistently throughout. So it happens within the therapy. And then it also allows us to report out to the managers of the therapists, how therapists are doing with their performance, and to employers about the impact that we're having. We're able to say, like, hey, this is the percentage of patients we're treating are kind of on track. Our system actually models what an expected treatment response is. And we can look at, like, how are we doing compared to what the modeling predicted, and report that out to the employers we work with. So we're actually able to say, okay, 71% of your population who are seeing mental health are progressing as we would expect. And that's, I think that's really powerful information to be able to provide.
Yeah. Sylvia, from your perspective, you're the doctor in the equation, right? And so, you started off talking about, hey, you sensed, and some screening data, you said, hey, look, there's an issue here, and you've helped them find their way to Carter or Michael. And then on the flip side, how do you experience them improving? Are you able to see that? Are you able to understand that progress is being made? And how do you observe that?
Absolutely. I mean, we still continue to provide them with periodic SDOH screeners. I'm able to speak to their mental health providers as well to know, what their outcomes are like. So we're following them along the path as the mental health providers do. Of course, in a different from a different aspect as well, because in what's important about mental health is that also impacts their physical health. So we have other markers, a little bit less subjective, of course, many a times, but we're all aiming towards the same goals, which is to keep our members healthy or make them healthier than they already are.
Yeah, Sylvia, it's an interesting that you added that point, because I was just going to add, is it's like, not only is it us helping you, helping us, but we try to help you as well, as when we're seeing individuals coming in with concerns of such as adjustment to illness or management of diabetes, or some of our individuals with these chronic health outcomes. One of the things that's really challenging, I know I collaborate with a couple of my providers on some individuals with why am I blanking on, the autoimmune disorders, and the stress of that disorder sometimes leads them to disengage. And we can catch those by working closely together. We can help catch them from disengaging earlier, so that they don't find themselves in the ER and having a huge bill at the end of the day, because they're maintaining their engagement along the way because we're managing the stress of that chronic illness.
Absolutely. I mean, and then to add to your point, I've had many a time situations where I'll give an example where I had a patient that I was struggling to have the patient complete their cancer screenings. And they got into mental health because they had some struggles they were dealing with. And the mental health provider was the one actually able to get them in for those, for the mammogram, for a colonoscopy and such. So we're working together. I'm not just that one practitioner, struggling to solve for that. So that makes a huge impact.
And I just want to jump in. I think, Sylvia, you said something that's so important, and that's, the mind and body are connected. They influence each other. And one of the things that's really driven me a little bit nuts over the last few years, there's so much venture capital money going into mental health solutions, and everybody's trying to solve for it. And it keeps going into these kind of siloed mental health solutions. And I think those came to be because, obviously payers were struggling to provide adequate mental health care. There were a lot of people who wanted privacy around their mental health and felt like it needed to be fragmented off in some way. But that's actually not the way that our bodies exist. They heavily influence each other. And when the care providers who are treating one part are fragmented from the people who are treating the rest, that's not going to create great care. And for people who have chronic medical conditions, so many of them develop mental health concerns as well. It's so important for the providers to be able to collaborate on what that treatment plan looks like and work together to make sure that that person's getting better, and just get concerned that the approaches that we're taking as a healthcare industry aren't facilitating that.
Let me kind of transition a little bit. The hot topic in the country today is social determinants of health and health equity, right? Man, I know it's hot when I start to see conferences all over the place, because those conference venues know they can make money by doing a conference on health equity or social determinants of health. And then I look at the agendas and I'm like, gosh, there's just a lot of talk about nothing. Nate's opinion, caveat. But we serve a broad selection of commercial members, right? We have high-tech employees, financial firms, retail workforces, distribution center employees, all socioeconomic and demographic levels that you can imagine. And I'm just really curious, at the root cause of a lot of these mental health issues starts to be some of these social determinants that impact their health. How are we identifying and actually addressing some of these issues in our care model? And I'd love to hear from each of you on this one.
I think we do it on both ends. I know we have our mental health screener also addresses, asks about social determinants of health, as do the ones done by our physician colleagues. And the way we really try to address them is kind of trying to know where we can add value to, because people are coming in for concerns about food access or housing insecurity or alcohol abuse or intimate partner violence and things of those natures, or some of the things that we screen for, and seeing how we can help an individual to work through those things so that these things that may be impacting them from living their best lives can be less restrictive. And I think as a whole, is one of the things that we're doing to address this kind of issue of health equity is not just increasing access, because access occurs. I was talking with my market manager the other day, is that, yeah, there's access to providers in a lot of our communities, but sometimes those aren't the best providers. And I think what we're able to do is provide high quality providers in a collaborative setting to address these complex difficulties in a comprehensive manner that create a really good, lead to better outcomes for these individuals that may often find themselves finding a lot of dead ends when they do engage in healthcare when typically offered.
Let me interject real quick. I love that, Carter. I think one of the hard challenges that maybe people on the phone might be thinking is like, hey, screening for these SDOH issues is one thing, but reaching through when loneliness or isolation is the problem, when transportation is the problem. I mean, you guys are licensed therapists and doctors. How do you help members that come in with some of these challenges? How are we able to lift up, or what resources do we have that are able to kind of lift up and help them?
It's interesting. Anytime we're in a kind of a new community, our care navigators actually build out a resource book. and they actually get to know all of the resources in the community for those things. They're aware of what the employer benefits look like. And so we have a kind of a guidebook to try and help people. And we've had care navigators help somebody who was in danger of being evicted right before Christmas, and they were able to kind of tap into community resources, find rent support for that person, and help them stay in their homes so they weren't, you know, homeless on the holidays. There are things like that we're able to do. We're also able to have these conversations with employers. We have the data on what percentage of their population is screening positive for these things. And it can be a conversation like, hey, do we need to add a social worker to this particular clinic who can help really, really do deep dives into community resources and help people with those things. Some of the social determinants have easier solutions than others. Loneliness is coming up quite a bit, and we built out a whole loneliness program at Crossover that our health coaches or our mental health providers can use to help people connect and not feel so lonely in their lives. So we can, you know, we have a lot of ways that we do approach it.
Great.
And to add to that, I think we take a very personalized approach to it, because not only are we identifying those issues, but we're meeting the patient where they need to be met. So for example, there may be an individual that would benefit from having access to a provider within Crossover. They may benefit from accessing our Be Well content, which is the educational content, or they may need access to community resources, which again, Michael pointed out, we have excellent care navigators that have, you know, a database of community resources, as well as in client resources. We definitely partner heavily with our clients that we work with their own resources, so third party. And I think that's important to personalize that approach, because it's not a one size fits all.
Yeah, thanks for that, Sylvia. The other topic that came up was the health equity topic, right? And we've talked about this a decent amount, and I've always thought, you know, it's a range of complex issues related to health equity. Also, not a fastball down the issue, single solution effort that fixes it. And I've been focused on some of the short-term solutions, like creating the right access and affordability so people have that. The one daunting issue that I see that takes time, and Carter, you had a good response to this, but takes time to fix, is actually making sure that the affordable access to mental health, the simple access to mental health, but that the mental health providers and the doctors that are treating the members can understand them, that they look like them, they understand their issues, that they have confidence that they're going to get the best care from them. And that is, in my mind, sometimes a struggle, because sometimes there's very specific communities that, you know, you want to be sensitive to. And so, you know, what has been your experience, Carter, Michael, Sylvia, about how we're able to step in and start to create solutions for that, to make sure that we're finding that connection between the provider and the member, so the member feels like, okay, this person understands me, I can actually get the care that I need from him or her?
Yeah, thanks for asking that question. I think it's a really complex one, and I think we try to address it from a number of different areas. Is one, like, I think about the Metro Detroit area. It's one of extremely culturally diverse, where there's a large Chaldean population. The largest Arab population outside of the Middle East is 7 minutes outside of downtown Detroit, and all these areas can exist all around one another. Providers is trying to hire providers that are from these communities, that know what these communities have challenges with, and are culturally competent about the challenges of them and how to address them, so that individuals feel as if they're not just saying at talking to someone that has no reference or understanding of what these difficulties may look like. And then once providers are hired, maybe not everyone is from these communities, but also developing programming and understand within our maybe our local huddles, but also beyond our local huddles, to help train providers to be culturally competent on all the complex issues that are constantly changing and evolving, and we're helpful in trying to address difficulties in the LGBTQ plus community, or challenges that may be occurring in the African American community or the Hispanic community locally, trying to make sure that our providers are aware of those difficulties and how they may be representing when those individuals do come in the doors.
I want to be sensitive on our time. I appreciate that response, Carter. There are some questions coming in, so let me see if I can address some of these questions. One of them is about the stigma of mental health. You guys are serving commercial populations. Are you finding that people are still comfortable coming into an employer-sponsored health clinic to get mental health issues? Is there a stigma related to that? How should employers and consultants think about the comfort of seeking mental health at an on-site health center or an employer-sponsored health center?
Yeah, I think we've come a long way with kind of openness around mental health, and I think people are more willing, and I think especially in our younger populations, we see more willingness to engage in mental health services. It's just viewed as more normal. But geographically and within certain cultures, there is still a lot of stigma, period, around mental health services. And I think this is also where having an integrated system, I think, works really well. I think when you tell somebody who's maybe a little bit ambivalent or unsure about mental health that you think they would benefit, and here's the number to call and go get yourself connected, the number of those people who fall off and don't follow through on care is significant. And I think, again, to Sylvia's point, when the primary care doc can attest to the provider, maybe even like Carter mentioned, be able to come in and actually introduce themselves, that can really help open the door for people who are really needing the care but not quite sure about it. And so I think that that really, really helps.
Great. There's another question on EAP. Does offering mental health through EAP work?
The definition of EAP has broadened significantly over the last few years. Like Lyra bills themselves.
You're smiling, Michael. I'm getting a sense that you don't think it works, so you've got a thought on this. Tell us the truth.
I think there's some EAPs who are doing some really good things out there, and they do what they can. We know EAPs are often not well utilized, and the quality providers on those networks aren't always great. And I've just also experienced EAPs. One, if they provide any data about what's happening, it's utilization, it's not outcomes. And so we don't know if people are actually getting better. And two, I've seen EAPs overpromise what they can actually deliver on. We had one employer where we were having that social worker conversation, like, hey, we think you would actually benefit. Well, we think our EAP can help people navigate the housing in their community. And the EAP said that they could do that. And no, they can't. And if an EAP is telling you that they can, from 1,000 miles away, help somebody find housing, that's dishonest. And so I get a little bit concerned about some of what EAPs have promised that they can do.
There's a follow-up question that popped up. Is crossover an EAP?
We're not, right? And I get this question a lot, even when I'm interviewing therapists, for jobs. They say, "Is this like an EAP?" And we're not. We're a health benefit, and the goal is always that we're their primary care home, right? Like the primary care doctor becomes an ongoing relationship that they have with us, and we have these other service lines available to them as they need. We're not going to. We don't have session limits. EAPs always do. We definitely try to be, briefer in our treatment for a lot of different reasons, but we don't have anything that says we have to be. So we have a lot more flexibility than an EAP would have.
I do know a couple of our employers, I don't know how they've distinguished it, have designated us as the EAP so that the member gets those EAP qualified visits at no charge, whether it's 5, 6, 7, whatever it is. We're not that technical EAP, but we're designated for the purposes of the covered visit. It's slightly beneficial to the members so that they don't have to pay those first 5 or 6, 7 visits.
Yeah, we've done that in a few situations where there was an existing EAP benefit, and we kind of piggybacked onto that, particularly for high deductible health plans where we have to have a fair market value for visits, that can be really cost prohibitive for people. And so we've partnered with EAPs who are on the benefits to kind of utilize the free visits, and they can choose. They can get their free visits through the EAP. They can get their free visits through us. Either way is fine. We just want them getting help, and that's worked out really well.
Gotcha.
I think the one of the benefits of being able to have those relationships with those employers, it has been an opportunity when people do come in the door through us, whether it's be utilizing their EAP program or not, they find out that they're getting a higher level of care than from the community. And then when they try, maybe even when they run out of the EAP sessions, like, hey, maybe I'll try a community provider, they find themselves coming back. At least I've had that a lot of my providers had that situation. It's like, oh, this person ran out of their EAP sessions, but tends to be a little bit cost prohibitive for them to attend sessions more regularly. But the relationships that they build within our network, within our walls, tend to help them stay connected in their care. So they're addressing their care in a more preventative way rather than a reactive way when, say, the problem becomes so big where they're having to go to the emergency room or things of that nature.
Great, thanks, Carter. We've just got a couple minutes left, and I want to punch through on some of these. This is an active audience. Thank you for your questions. One question came in. So Sylvia, you're talking about how you're able to spend more time with your patients. How are you able to do that versus the typical PCP? How can you deliver better care or spend more time? Like how does the model help you do that?
Absolutely. So our physical exams are an hour long. So that really gives us ample time to go through a proper history, get to know the individual, do a proper exam. We actually even are able to run labs and have lab results at the end of the visit. So those can be some actionable items. Then our office visits are half an hour. So again, giving us adequate time with patients. And then not to mention, we do a lot of asynchronous care with patients. So I always make myself readily accessible to patients. So at the end of the visit, I'll tell them, you have a platform, account, please utilize it, reach out to me if need be. So we're having that ongoing communication with the patient as well. So it really leads
Excellent.
to a better health experience.
Yeah, I always say, I think we have wonderful providers at Crossover. I think the magic isn't that we hire smarter people. I think to become a physician or a therapist, it's tremendously challenging. I think the care model where you talked about the tools that you have, the additional time that you have, Sylvia, is really the magic to allow you to be fully utilized versus just 5 minutes of Sylvia being utilized, right? And so I think that's really a big piece of the magic. A couple other questions. One's on pediatrics and children's mental health. We don't do that. We don't get into the children's pediatric. The question's actually regarding children's mental health crisis. What is a pediatrician's role in identification, referral, and treatment of child mental health? I think that we're probably not the best to answer that. You say that's true, Michael and Carter, Sylvia?
I mean, I would say it's the same as the adult primary care physician's responsibility. I think, having good screening in place, even for kids, and assessing for mental health concerns and referring when appropriate is just as important in pediatric care as it is in adult care.
I would
go ahead, Carter. You agree with that?
Yeah, I agree with what you're saying, Michael, and if individuals are presenting in that level of crisis, getting them connected with our care navigation system and care navigators has been an awesome resource for us.
Great. Another one is, how do you track measurement-based care? Well, Michael and team actually wrote a white paper about measurement-based care. It's on our website. You can go there and download it or email us and we can get it out to you. That's a great one. Another one is, how do you know that the referral that you made to mental health actually took place? Like, how do you know your members are going to mental health? Sylvia, from a provider's perspective.
I can access the provider directly and make sure that they have gone in for their visits. Not to mention, if we are referring to the outside, if there is a necessity for that, our care navigators do an excellent job in closing that loop as well. So I think within crossover, as well as with referrals to the community, we're always closing that loop, and circling back to the patients to see, was there a barrier? How can we, better service you? What can we do to provide that assistance?
And our medical record is also shared, and I know sometimes that people have different perspectives on that, but primary care doctors are able to actually see the notes from the mental health providers, and they can see that visits are happening and see what's happening in those visits.
Great. Last question then. Where does neurosciences and brain health fit in to behavioral health?
Carter, I'd love your perspective on it too. I think, there's still so much about the brain we don't understand. It's incredibly complex. And I think as therapists, we're constantly trying to grow and learn and keep up with what's happening. I think there's so much mindfulness work in mental health now, and there's been some amazing neuroscience research about what happens to the brain when people are meditating regularly. We're really trying to keep up with those trends. I think, anything we can do to be helpful and help people feel better, we want to do. And I think that brain research is incredibly important to the work that we do.
Yeah, just to piggyback on that, Michael, is that I think where a lot of its value ends up occurring is, especially when I'm talking with patients that are maybe find themselves being very reactive to emotions, or discussing these long-standing difficulties of trauma, discussing the neuroscience behind how trauma can live in the body, or how that reactivity to those things can actually increase their experience of chronic pain and things of that nature. So that's one of a lot of the values that we that neuroscience and brain health can really be beneficial for patients, is helping them to have a better understanding of, like, hey, this is the active experience that's occurring for you within your body at the moment, and this is how we're trying to address it.
It's really interesting. We're going to be launching a new section of our Be Well page soon, called Mental Health Essentials, and it's things that people can do to maintain their mental health. We talk so much about physical health, diet, exercise, these things, but what do you do so that maybe you don't need a therapist? How do you maintain good mental health? And one of those sections is around the kind of the science of happiness, positive psychology, and what we've learned about people who report on average that they're just happy in life. Like what have we learned from those? And that includes neuroscience research, that includes behaviors and skills, and it's really interesting to look at. So I'm excited to get that information out there to our members soon.
Excellent. Well, listen, I know we're just a couple minutes over time. Really appreciate your feedback. I know you guys, and I appreciate the practice of your profession and individually helping our members find balance in their lives through mental health and taking care of their bodies. And so thank you so much for what you do day in and day out professionally, and for spending a few minutes with us today, sharing a little bit more about that. So thanks, everyone. If you have any questions, shoot us an email. We look forward to sharing these perspectives with you, and we'll do another one here shortly. Take care. We'll see you.